for folks to join. Okay, great. I think we will go ahead and get started. Good afternoon, everybody. Thank you so much for joining us today for our community conversations on COVID-19 from UW Medicine and the Office of Healthcare Equity. My name is Priscilla. My pronouns are she, her, and I work as our Community and Workforce Engagement Specialist here in our Office of Healthcare Equity. I will turn it over to Dr. Chopra for the rest of the introductions.
Thank you, Priscilla. Welcome everyone to Community Conversations. Thank you for joining us today. We will be talking about COVID-19 updates on antivirals as well as on the monkeypox virus as well. Thank you so much, Dr. Lynch, Dr. John Lynch, who is Medical Director, Infection Prevention and Control, and Associate Medical Director at Harborview Medical Center. Thank you for joining us. And thank you, Priscilla. Priscilla is with our communications team at UW. Priscilla, we'll start off with you. There are some community resources that people who do have COVID-19 can access. Can you please tell us about those? Because not many people know about them.
Absolutely. I'm also going to put a link in our chat for the program. So I unfortunately had COVID recently. It was not severe thanks to our vaccinations. I was able to stay at home and just kind of deal with a not great flu, I guess is how I would explain it. During my time with COVID, I was connected to a program called Care Connect Washington. It is a financial and food assistance program throughout the state of Washington. There is a phone number that you call, and then somebody from the program will reach out to you, do about a 30-minute for rent and utility assistance. This can also go towards your phone bill, I believe. The utility assistance and the mortgage assistance, they said as well. The $1,500 is a flat rate per household. You do not need to provide any sort of income information. They did not ask me for any sort of W-2s or anything like that. They just went through a series of questions. And then they provided a grocery delivery from Safeway that came within 2 days of my phone call with the program. They sent about $130 worth of groceries free of charge, including pantry items, toilet paper, paper towels, medicine, soap, and then, you know, milk, eggs, cheese, a bunch of different kinds of meats. Which was pretty incredible, especially when you're at home in quarantine and unable to go out. So I will again send this in the chat, but it's pretty amazing. I don't believe that the contact tracers offer this to you when they call you to tell you that you've tested positive. So again, I will put the number, but if they do call you, you can always say, I'm interested in food and financial resources. I will say for their financial resources, it does take some time. I used it for part of a phone bill and the rest for rent. The phone bill was quite fast. They actually pay the company directly. They just need a copy of your bill. But the rent assistance does take about 2 months in order to come in. And what they did is they worked directly with my landlord, conversed with them via email to get the documents that they needed, a copy of your lease, and I'm just waiting for that to come in still. However, with your landlord, you can always let them know this is going on and perhaps make some sort of arrangements if you need to while you wait for that assistance to come through. So please share this information out to anybody, everybody. It is federally funded. It's been around since December of 2020. I am heartbroken to hear that not a lot of people know about this, but I am looking forward to you all spreading the word to your community to help anybody out that needs these resources if you unfortunately contract COVID.
Thank you so much. Will you be putting in the link for the website as well?
Yes,
Priscilla?
I will put the link in the chat right now.
Thank you. Thank you very much.
Mm-hmm.
So let's go ahead and get started with the questions that we have from the community. Dr. Lynch, we'll start off with, with masking. What do you recommend with regards to masking? The community transmission is high, and does one-way masking work at this point?
Sure thing. So first, thanks for having me on, and hi everyone. I hope you're doing okay wherever you are. Priscilla, I'm so glad that you're feeling well and are recovering, even if it's a little bit slower than you're hoping to happen. And thanks for sharing those resources. I wasn't aware of them at all either, so I will be sharing them as well. So masking. So here's one way to think about this, is that we recognize that it's been a long haul for everyone. It's 2.5 years into this. Wearing masks isn't super, fun. It's not always comfortable. There's lots of things that are involved. But what we do know is that they can play a really important role in slowing down transmission. And what I want to be clear about here is that, the optimal situation is that whenever we're in public indoor settings or in any big crowd, even outdoors, wearing masks really does protect you and protects the people around you. The data is really clear on this. The higher the level of mask, the better off it is. So, we talk about surgical masks are better than cloth masks. KN95s, KF94s are better. N95 is even better than that. And so what I recommend is finding something that works, that's comfortable, that's easy, and fits your face. And I also recognize that people do, they want to engage in their lives a little bit more, and that's completely reasonable. And the way I sort of think about it is that even if you're not wearing your mask all the time in those indoor public settings, some of the time is better than not at all. And so the metaphor that I use is to think about it like speed bumps. Anything we can do to slow down transmission is good. So if you're going to go to a restaurant where there's other people, wearing a mask until you're seated and ready to eat, right? That means you're not interacting with, for instance, the host or hostess without a mask on, or maybe you're decreasing the amount of time you're around other people unmasked. And so, or if you're going into a sporting event, leave your mask on until it's time to, have a snack or something. And when the snack's done, put it back on. Those things really do have meaningful ways to interrupt transmission, sort of slow things down at a time, like you're saying, Dr. Chopra, where rates are really high.
So it's probably, assessing our own risks, going to the grocery store, going to a restaurant, like you said, going to Costco, indoor places, keep your masks on. And as we had talked, Dr. Lynch, at our previous town hall, if you have a higher grade mask like a KN95 or N95, don't discard it, don't throw it away, because that can come in handy. The same would apply for schools as well, right, Dr. Lynch? Just assess your own risk, and kids can continue to wear masks if they choose to, because again, that's indoors and again, a place where transmission could happen.
Absolutely. Schools are definitely, if you look at, publicly available data, the Seattle public school system and other school systems, they all have dashboards, and the rate of transmission in schools is very high. Now, I want to also recognize, that, not every kid who gets COVID is going to get very, very sick. The vast majority of them don't, but they still do many of them still get ill. But what's really important here is that it really causes a lot of trouble for themselves, for the kids and their families, right? So if you have a sick kid at home, someone's going to have to stay home and help take care of that kid. They're going to miss days of school. They're going to miss days of sports. The parent's going to miss, or caretaker's going to miss days of work, right? And creates this, kind of cascade of events that's really challenging. And so, yeah, supporting our youth in wearing masks at school is really, I think, still really, really important, because we are all connected in ways that we don't anticipate. And, you said, I think you're right, Dr. Chopra, think about our own risk. If I'm immunocompromised, or if I live with someone who's immunocompromised, that's certainly really important. But what I really want to emphasize is that we are all connected in ways that we don't even understand. 6 degrees from me is someone who lives in a nursing home, who is got, an immune system that maybe isn't working well. And if they get COVID, their risk of dying is really high. And I don't even know that person, but I know that connection, that series of connections exists in ways that I can't map out, but are definitely there. And so we all have to think about the collective. How do we assess our own risk, but also assess the risk of our community in keeping everyone safe?
That's very, very, a very important point. Dr. Lynch, now that we have oral antiviral medications available, primary care physicians are prescribing it. UW Medicine has opened up, urgent care visits, even virtually. And we are, assessing patients to see if they qualify for Paxlovid and molnupiravir. Could you please talk a little bit about how do people know that they would be eligible for Paxlovid? What should someone in the community do when they test positive for COVID? Should they reach out to their physician, or is there some information that's available to them to decide or to assess whether they would be candidates for Paxlovid?
Yeah, I think that's a really important question. So there's this, I'd say the medications that are being used the most right now is this medication Paxlovid, the one you mentioned. There is the second one, molnupiravir. What's good about Paxlovid is that we have enough of it. It's out there. It's available. So people shouldn't hesitate to reach out to their primary care provider for help and for guidance. And so my recommendation on this is, yes, you can go to resources. So for instance, if you do a web search for CDC Paxlovid, it'll give you a list of the folks who are eligible, because not everyone is going to benefit from it. And so there's a list there, but sometimes it's not always perfectly clear. And it's really that communication with a provider, either through an urgent care, right, televisit, or a primary care provider, that can really be very helpful in talking through things and understanding your personal risk. It as much as like we want to make it super cut and dried for everyone, we have to recognize that we're moving into a management phase of the pandemic. Dr. Vicky Fung, who is the medical director for the UW primary care clinics, is a great colleague of mine, has sort of phrased it. We're in the outpatient phase of the pandemic in many ways. We certainly have more patients in the hospitals, but not like we did during January or Delta. And so it's really about how do we manage people outside of the hospital? And part of it is how to assess them for treatment. And so I would recommend looking at the CDC document, but also calling primary care doctor. And if you don't know, please do reach out through the resources that Dr. Chopra mentioned, because we're probably not getting as many people treated as we really should be.
And I also want to let people know that there is a window, like a 5-day window, where we can treat you. So if you test positive and reach out to us in that time, we can assess, your eligibility for the medication. There is a process of us going through your medical conditions and assessing whether you meet the eligibility criteria. And there is a lengthy sort of guideline or NIH guidelines that we are following to see if you are eligible or not. Also to see if your kidneys are healthy enough for you to get this medication. In addition, the biggest point is to see if this medication would interact with any of your other medicines. Sometimes we can cut, in half the dosage of the interacting medications. At other times, we can ask you to hold those medications during the duration of treatment. But it is very important that we see you in those 5 days so we can decide whether you are eligible or not. Dr. Lynch, I want to take a minute and talk about the side effects. Some people are deterred by the side effects of Paxlovid, and they think that they are better off not taking the medication because they don't want to, go through the nausea, the vomiting, and diarrhea. What has been your experience with this? I mean, is that something that they should, is that something that they should take into account while, when deciding whether to go on this medication, or how would you advise people?
Yeah, so, I would say that yes, the side effects that you just described are pretty common. And it sounds like you're smiling. It sounds like you've heard the same side effects from probably some of your patients. It seems pretty common, but I would argue that I wouldn't let it deter me. These medications have good science behind them, that they prevent people's disease from getting to advance to the point where they need to end up in the hospital. And we know that's really, really important. It's the last thing we want anyone to get to is that they need to be admitted to the hospital for COVID. It takes them away from their households, their families, their loved ones, and obviously usually is associated with being sick and out of their normal lives longer. And so, yes, there may be a few days of maybe some GI discomfort, but it's not harmful, no long-term negative effects, and it can be very effective about keeping you safe.
Also, people who are above the age of 12, it's not approved for, younger than 12 years of age, but above the age of 12 could be eligible for this medication. The other thing, Dr. Lynch, that I would like to, if you can please talk about this a little bit. Not all people meet the criteria for the medication. Mm-hmm. Some young, healthy individuals, are making appointments, hoping that they will get the medication, and they are disappointed, and rightfully so, when they don't get the medication. What would you say to that? I mean, should people go in to the appointment assuming that they will come out with Paxlovid? And if they are not getting it, is that something that's going to be dangerous for them?
Yeah, this is a really important question as well, Dr. Chopra. So thanks for bringing it up. So I like to think of this just like we think about influenza. So influenza, we have a medication. It's okay. It's a good medicine, and we give it to people in higher risk groups. For instance, pregnancy, or people with other medical conditions like heart disease or lung disease, or when they are sick enough to come into the hospital. And it's the same situation here. Is what we're really trying to do is give a medication based on the science that we have that tells us that it helps them, right? That the downside of the GI distress and all that evaluation has an upside. And the upside for folks with who are at higher risk for ending up in the hospital, so people with lung disease or heart disease, or people who are older or who are immunocompromised, right? They're at high risk for ending up in the hospital. And we know that Paxlovid reduces that risk. For young people, the risk of ending up in the hospital with COVID is pretty low. And so the amount of benefit you get from taking medication is not been demonstrated to be there. And so, taking Paxlovid for a young, healthy adult probably isn't going to buy you that much more safety with COVID compared to someone who's older or has those medical problems. And so I can understand if you might feel disappointed, but the good news is being young and healthy provides a lot of protection against COVID-19. It has been remarkable to watch how even without other medical problems, the distribution of morbidity, how sick a person gets over the lifespan, really how strong the association is with age, and so really trying to focus on the people with the highest risks is where we want to use this medication.
Thank you so much. I want to talk a little bit about this phenomena that is Paxlovid rebound. And I have seen a couple of patients with this in my practice, but it's so little is known about it. Is this the virus getting resistant, or is this the patient not responding? Should the patient repeat a course of Paxlovid? What are your thoughts on that?
Yeah, this is a really interesting question that you're right, Dr. Chopra, we don't have all the answers to. So I want to make sure we hit some of the really important points here. So as Dr. Chopra mentioned, we give Paxlovid and we have to give it within 5 days of symptom onset. So you have to have a positive test and it has to be within 5 days of symptom onset. And what we know is we give the course of medications is that in some people, and it's not clear, which group but it happens not rarely, is that people will get better. And even if we test them for COVID, their tests become negative. And then a few days later, they have symptoms come back and their tests become positive again. So the most important things to take home here are probably just for knowledge are two things. One is that this, when people got better, the CDC recommendations is you can come out of isolation. What we know now is with those symptoms that come back, if they do come back, we want you to go back into isolation because we might be concerned that you might be able to transmit virus at that point again. And because those tests become positive again. The second important point here, because I know it's a sensible question, is should I get treated again? And right now, there's no recommendation to treat again. And in fact, they say do not treat again. So we would just at that second rebound, or that first rebound, I should say, the recommendation is to go back in isolation and just treat symptomatically. No more additional courses of Paxlovid. Now, people are asking the question, should we be giving longer courses of Paxlovid? Should we be treating again? And those questions are being evaluated now. But right now, as far as we know, we wouldn't give a second course. The question is, why is this happening? Is it mutating? No evidence that the virus becomes resistant to Paxlovid, which is really good news. What may be happening is that because of people's vaccination status, so their immune system, right, is primed to react to infection, or they've had COVID in the past, and so their immune system is primed to react to COVID, is that as soon as there's any COVID in our body, our immune systems start kicking in, and that's what really drives our symptoms. So it may be that our symptoms pop up before there's very much virus there at all. And what we're doing is we're giving the Paxlovid maybe too early in the course of infection because our bodies are primed and we start having symptoms before there's even a lot of virus. And maybe what we'll learn is that you need to wait a little bit longer, or maybe those longer courses of Paxlovid are important. But again, those are unknown answers right now to a really important question. So no evidence of resistance, but the take home there, really important points are, if you do have that rebound, call your doctor, call your provider, go back in isolation, recognize that another course of Paxlovid is not going to be recommended until we know more.
Thank you. This was really, really important information. And I'm sure that, as primary care docs, we'll be addressing more and more of it. Dr. Lynch, this brings me to this important, as you mentioned, you keep testing positive for COVID. We have patients now who are testing positive for 8 weeks, 9 weeks. What should their approach be towards isolation? Can they go back to work? Can they travel? What should, how can they go back to functioning as their previous?
Yeah, so just to get everyone on the same page here, we really have two main types of tests for COVID-19. We have a PCR test, which looks for the genetic material of the virus. And we have an antigen test, which looks at sort of the pieces of the virus, like the proteins of the virus. And what we know is that when you look for the genetic material using the PCR, even after the virus is dead, that test can be positive. And that's why we don't recommend reusing those tests within the first 3 months after infection, because it's very common to see them positive, even out as far as, that many days. And in some people who are very immunocompromised, it may even be much longer. And, again, those we deal with on a case-by-case basis. The antigen test is what we call less sensitive because it's picking up the pieces of the virus, the actual kind of shell, the structure of it. It's you need a lot more there. And the antigen tests tend to be more closely associated with having functional virus around, so stuff that could potentially be infectious. And what we do see is that it does go up with infection, often very early, particularly with the variants we're dealing with right now. And then it does tend to go away over time. And generally with people's symptoms resolution, the amount of there goes down and down and down. And so when we think about which tests are positive, PCR tests, I expect those to be positive for weeks and weeks, if not months. And I strongly recommend not retesting unless you have symptoms. And that's going to need to be figured out probably with a provider, because it can be complicated. There's other respiratory viruses out there. With the antigen tests, I expect those to become negative, generally within a couple of weeks of illness, but otherwise don't make me concerned. And so this is why I strongly support the CDC recommendations around isolation, right? The recommendations out there are time-based because they're based on looking at big populations and risk for transmission rather than the tests themselves. What I really care about is if I get infected, when can I safely leave my home and not put other people at risk? And I think the CDC guidance around isolation right now makes sense. And using symptoms as a guide can also be really helpful, right? And if I feel better and no fever, my cough and stuff is gone, then that's also much safer.
This is really, really important for people, especially who are traveling or who are, sometimes we have patients overseas and they need to travel back. And I think ordering the antigen test instead of the PCR test is something that we really need to keep in mind, and as primary care docs and patients as well. Dr. Lynch, I'll touch upon a little bit on the vaccines. If somebody has not been boosted, they just got COVID, should they still go ahead and get their booster? And the same is for the fourth dose as well. Should they be getting their booster after they've had the infection?
Yes. So the clearest, simplest answer here is yes. There is no reason to delay or to space out your vaccines, your primary series, or any of the boosters based on infection. As soon as you have recovered, or your patients recovered, or your family members recovered from COVID-19, they're eligible to get vaccinated. I think in one of the questions you sent me a report from someone saying, hey, a pharmacist told me to wait 4 weeks. That is not recommended. You should get your vaccinations and your boosters as soon as you feel well. There's no reason to delay. And there are still benefits to getting vaccinated, even if you have had COVID, vaccinated or boosted. We know that being vaccinated boosted has protection against subsequent infection, and it may also protect people against long COVID, and which is a huge and emerging problem. And I think Dr. Chopra probably has a lot of experience with this. It is a huge problem that we're seeing out in the world.
Dr. Lynch, as far as the vaccines go, are we expecting the variant-specific vaccines? If so, should people delay their boosters at all? And if we do expect these vaccines to come, will we be offered those vaccines?
Yeah, so I know that the vaccine companies are looking at Omicron-specific vaccines. So Omicron is the variant we're dealing with right now, and probably are going to be dealing with in the coming future, probably for the rest of this year. And so yes, they are working on Omicron-specific vaccines. I am hopeful for Omicron-specific vaccines this year. And yes, if they are developed, they will probably be like we deal with influenza vaccinations. They change every year, and we probably be dealing with a pattern like that. Given that, I would not delay. If you're eligible for a first or second booster, I would just follow the recommended course right now. There's no reason to think that if you got a booster or a second booster, if you're eligible, that's going to impact your Omicron-specific vaccination. Now, we always want time between vaccines, but there's, at this point, until we know more about a schedule and availability. I think getting fully boosted is scientifically supported at improving your safety. So don't delay your vaccines, don't delay your boosters based on this idea of subsequent vaccines this year.
There's a question in the chat as to any reports of side effects after the second booster.
You know, I'm seeing it all over the place. And Dr. Chopra, you probably have more experience with this in your practice, but I've heard the whole spectrum from this was so much easier than my primary series to other people saying it felt a lot like my primary series of my first vaccine. In general, I haven't heard any notable concerns about those second boosters really at all.
Yeah, I think the second boosters have been easier than the first booster even. Most of our patients have just reported some mild body aches and chills at the most, but recovered quickly after a day or so. So not a whole lot. Dr. Lynch, there's a question in the Q&A that I will club with one of the questions that we had received as well, which is about Paxlovid and any studies showing Paxlovid reduces the chances of getting long COVID. And the second part of this question is, why are we not treating patients with antivirals, patients who have long COVID? Why are we not treating them with Paxlovid?
Yeah, so I will try to look up that question. I don't know the answer. If I had to give a hypothesis, I would bet that early treatment with Paxlovid probably reduces the risk of long COVID. But I don't know the answer to that. And whether it's been studied, I think even the definition of what technically is long COVID there's a lot of different definitions out there. So is it symptoms that interfere with normal activities of daily living after 8 weeks, 10 weeks, 12 weeks? And I think the scientific community is still trying to settle on exactly what those things are. Is it persistent fatigue? Is it other serious things like we hear about blood clots and other things occurring in people later after infection? So I don't know the answer to the question. I can certainly look it up and get that answer back to you. The second part, though, is Paxlovid for the treatment of long COVID. So what we think is happening with long COVID, right, is not that there's any virus there, right? We know that the virus gets to lots of parts of our body, nervous system tissue and all kinds of parts of our bodies. But once we get past that acute infection, we actually clear the virus, but our immune system is now has what I call a maladaptive. It is now overacting for long periods of time. And it's sort of setting up what's called an inflammatory state that is leading to these persisting symptoms. And we're still trying to understand this. There are many other diseases out there, these what are called autoimmune diseases or rheumatological diseases, where our body is sort of fighting against itself. And long COVID may be much more like that. And the treatments are going to be more like that. And unfortunately, none of those conditions respond to the antivirals because the virus is gone. And so the question around would antivirals early, for instance, in a young, healthy person, reduce the risk for long COVID? I think it's a possibility, but it's a pretty hard question to answer. I'm sure people are looking at it. You need a definition of long COVID. You need a large number of people to get treated and to see what actually happens down the road. And I hope those studies are either ongoing or going to get started. But at the time being, and we know that antivirals at that point won't help that inflammatory state. We're going to have to look for other treatments.
It's really important what you said that, during active COVID, we have the virus, but during long COVID, we have what is an inflammatory response. It's not the actual virus itself. So that is why, Paxlovid has not been indicated in that condition. Dr. Lynch, people who are, who have mild infection and who are not displaying a lot of symptoms with their active COVID infection, what should they be doing? Obviously, they will be at home, isolating for the 5 days. What kind of supportive treatment should they look at? And when should they touch base with their primary care provider? So when we talk to patients in our primary care clinic and we tell them, hydration and, vitamin C, good old chicken soup, things like that, they are not always convinced. because here we are giving, antivirals on one hand, and on the other side, we are just telling them take Tylenol and rest.
Mhm.
So what would you say about that? Is there like a recommended home treatment plan for patients?
Well, I think you're more of an expert in this than I am, Dr. Chopra. And maybe Priscilla could also tell us what worked for
Yes.
her. But I would say that there's no specific, group of treatments for people who are at home, who are safe at home, right? Who are breathing well, who are eating and drinking normally. There's no things that we know that make things better or increase the sort of clearance of virus. The things that are really helpful are the things we've sort of already talked about, which is vaccination and boosting, because that's going to prep your immune system to prevent sort of the progression of the disease, the more serious outcomes of the disease. And so it's sort of like by taking that preemptive step, it's probably going to set you up the best that if you do get infected, the symptoms will be minimal. I don't know, Priscilla or Dr. Chopra, what you guys have done in your recommendations or personally that may have helped beyond acetaminophen, Tylenol, and chicken soup, or other things that taste good.
Priscilla, you want to share your experiences?
Yes, I would say for me, I'm part Filipino, so I eat a lot of arroz caldo, which is kind of like the Filipino version of chicken noodle soup. Hydration, I stayed really hydrated. One of the things that they send you in that Safeway grocery is a pack of bottled water as well as a 12-pack of Gatorade. So I stayed hydrated with Gatorade, water, really just rested as much as I could. I mean, that was pretty much it. I will say for me, COVID was quite interesting as the symptoms changed from day to day. So one day it was sore throat. The next day it was a really bad cough. The next day it was congestion. So that was really interesting of sort of these moving symptoms. And there were days where I felt a little bit better, and the next day I felt like I took a step back. So it's really just time in your body, I would say, but staying hydrated, eating as much as you can when you can, resting.
Yes, if you are not immunized, you definitely want to get in touch with your primary care doctor. If you are immunized and you are young and you don't have any other underlying health conditions, hydration is probably the number one best friend, along with good old home remedies like you mentioned, Priscilla. Dr. Lynch, how do you anticipate the summer will look like? You mentioned in your newsletter yesterday that the hospitalizations are coming down. What would you anticipate the coming months? How are they going to be with people traveling and kids out of school?
Yes. So, I think I probably said on community conversations in the past that anybody who says they know what's going to happen, I don't know how much I can really trust that. So I don't know what's going to happen. What I think will happen is that case counts will go down, right? And especially if the weather gets better, as school gets out, right? Kids aren't inside. We do know a lot of kids get infected and they move COVID between families and other social groups. So I think getting kids out of school and outdoors is going to be a huge benefit for all of us. And then all of us as adults, when the weather is nicer in the Pacific Northwest, we tend to spend a little more time outdoors in the parks, in our backyards, and maybe even farther away, doing whatever we enjoy. And so those things are going to be really good. And that's going to contribute, I think, positively. So decreasing cases and infections. The tricky part is that we're in a surge right now. And this surge is linked to two factors. One is, how we've sort of normalized a lot of activities. What I would argue is wishfully normalizing a lot of activities, especially indoor activities. And that's school and things that adults are doing. The second part is that we have a very infectious variant. So in January, we had Omicron BA.1. Now we have BA.2, which is more infectious than BA.1. But underneath the surge we're having right now is BA BA.2.12, another variant that is more infectious than BA.2. And that's actually rising now. In Washington State, it's about 24% of all of the variants. On the East Coast and other parts of the US, it's the majority strain. So it's 60, 70%. And that's, as I said, more infectious than BA.2. And so this is the first time we've had two variants at once, sort of vying in the middle of a surge. So it's unclear to me whether the emergence of BA.2.12, more infectious than BA.2, whether it will prolong and make this surge just last longer, or whether good weather and the end of school is going to help us drive those case counts down. I'm hopeful that the summer is going to be a low number. In the northern part of the United States, because people are outside, we see the numbers tend to go pretty low, and I'm hopeful for the summer, for a really good summer with low COVID counts. So that's my fingers crossed. There's one more complicating part, is that we have the BA.2, this Omicron variant, BA.2.12 underneath it. It's going to probably take over BA.2. And way down below that is BA.4 and 5. Underneath that, it's about maybe just under 10%. And we don't know what's going to happen with those. They caused increased case counts in South Africa. They've been sort of scattered around the United States, and we just don't know how it's going to play out versus the other Omicron variants. So there's a lot of unknowns. But again, my fingers are crossed. When the weather gets good and school's out, that we'll see case counts go down, and that'll give us a breather so that we can prepare for the fall.
So fingers crossed that the summer will be a good one. But again, with the word of caution to continue masking in indoor spaces and in crowded spaces as well, and to please get your vaccines, get yourself boosted if you are not already. Dr. Lynch, now we are going to shift gears to monkeypox.
Mm-hmm.
What is this? We know that there is a case here. Who are the people at risk? How is it transmitted? And how worried should people be in the community?
Yeah, so I think it's important to be aware of monkeypox, but this is not COVID. This is not something that's going to lead, as far as we know, to anything remotely as large of a pandemic or epidemic or outbreak as COVID. And that's because it's transmitted in different ways. So we've known about monkeypox for a long time, first described over 50 years ago in monkeys. And we've seen cases occur and outbreaks occur sporadically, particularly in West Africa, where populations are more closely interacting with monkeys, either as foodstuff or through other activities, through rodents and other animals. And often in populations that have a lot of barriers to access to care, right? They're not able to get to higher level medical care. And so we've had outbreaks in the United States of this before, always associated with importation. So someone who's come from what's called an endemic region, a place where monkeypox is already and is always there to some extent, and bringing it to the United States. We had a outbreak associated with animals in the United States and the Midwest, I think a few years back, 2018, with about 70 people. And so this is not the first time we've dealt with this. What's different this time is that when we look at the number of cases, it's much larger. I think globally now we're over about 700 cases of monkeypox. In the United States, it's around 20, although we're going to probably see more. And we have one here in Western Washington we know of. What's different about this particular outbreak is the number, but also it's working through a network. And so of sort of people. And I want to be very cautious here. So monkeypox can infect anyone. The reason I say it's not as concerning as COVID is that you need to be really close to someone. So you need to have generally it's transmitted via droplets, like the stuff you see when people sneeze or cough, like the big droplets land on you, you touch it, you put it on your mucosal surfaces. It's associated with this rash that can open up, like pustules, like pimples, like rash, although it can look like lots of things. And when you touch those, like those can also lead to transmission. So it's that droplets and it's touching that rash that transmits it, which is different than COVID, right? Where it sprays, it sits up in a cloud around you, right? It can transmit even when you're like walk into a room with someone who just left. So it's harder to transmit. And what we're seeing right now is that it's moving between in networks of men who have sex with men. And I use that term very carefully here, right? It's and for everyone who's not familiar with it, I'm not saying gay men, because there's a lot of people out there who have sex with men, men who have sex with men who don't identify as gay. And I want to be very careful also that this doesn't mean that gay men or men who have sex with men are at higher risk for getting monkeypox. It's just moving in that community, but that anyone has the same risk of getting monkeypox should that interaction occur. It's just like thinking about other communities where there's friendships and interactions. It can move to those communities as well. And so right now we're seeing this transmission among networks of men who have sex with men. And so a lot of the communications being targeted to that community to be cautious around close contacts. But we also know that, infections in that community can move directly into other communities and start to lead to outbreaks wherever people are close together, who either, can get coughed on, or have intimate contact, sort of skin to skin contact. And so the challenge though, is that that prodrome, the symptoms that start with monkeypox look like a lot of other things: fever, just not feeling well, big lymph nodes before the rash happens. And so we're trying to keep the threshold low and get people tested. So I'm saying I think we're going to see more cases, but I doubt we're going to see something at all on the scale of COVID-19. And I hope we can get it under control pretty quickly here.
So Dr. Lynch, it's so as I understand correctly, it's by skin to skin contact but also by droplet.
That's right, droplets. So yeah, big saliva droplets.
So Dr. Lynch, does the smallpox vaccine, is it protective against monkeypox?
Yes, and so smallpox and monkeypox are in the same family, orthopox viruses. They actually look very similar. The morbidity and mortality associated with monkeypox is much lower, so people don't get as sick, and they don't, fortunately, don't die as frequently. The difference between smallpox and monkeypox clinically is that folks with monkeypox tend to get big lymph nodes, and that doesn't happen in smallpox. But fortunately, smallpox vaccination does have some amount of protection, and probably lifelong protection. So if you were born in the United States before 1972, you were probably smallpox vaccinated. In many other countries in the world, if you're born in another part of the world, continue their smallpox vaccinations beyond 1972. So it depends upon where you live. But for younger people in the United States, you're not smallpox vaccinated. Yeah, so that's sort of the summary.
So there is a question, by someone in the community. Are you really confident monkeypox isn't transmissible via aerosols? My networks are skeptical and nervous because the CDC insisted COVID was droplet transmission only for so long. Yeah,
listen, I totally agree with that. It's totally, that concern in that question is always a good one, because we did struggle with COVID in understanding its transmission patterns. And there's a lot of resistance to moving from, droplet to aerosol. The difference with monkeypox is that we've had monkeypox in animals and humans. We've known about it for the first human cases were in the 1970s, maybe even 1970. So it's been around for a long time. It's a DNA virus, unlike COVID or SARS-CoV-2, which is an RNA virus. RNA viruses make a lot of mistakes. They mutate really fast. DNA viruses they make mistakes, but they don't tend to mutate as quickly. And so we've had sort of this virus around for a long time, and people know about it. It's been studied. We've seen other outbreaks over the decades in West Africa. We've had them in the United States, and we've never seen transmissions and outbreaks occur like we've seen with COVID. And so our understanding of transmission dynamics, droplet, close skin contact, are supported with the real life experience over decades of monkeypox outbreaks everywhere in the world. And so I think it's always good to be skeptical, and I think we should keep our minds open for other modes of transmission for monkeypox. But for the moment, I feel pretty good that we're aware of it's not aerosol at this point.
And Dr. Lynch, is UW Medicine putting out any specific information on prevention of monkeypox for the community in general?
Yeah, so our focus right now has been on making sure our providers are aware and that the right folks are doing the screening and we have access to testing. As far as public notification, we're leaning on our public health colleagues because this is impacting right now, primarily men who have sex with men and gay men. The messaging is really being, it's global, right? It's everywhere, but it's really being pushed more heavily in that community so that folks are aware that they're taking the appropriate precautions and they're getting tested. On UW Medicine side, we have worked with folks who may have monkeypox. We've done the testing, and we're really about keeping our patients and our environment safe, as well as our healthcare workers. And we've done now a handful of what we call rule outs. So where we evaluate a patient, we do the testing, and we're doing all the right level of precautions. So I feel very confident that we're doing all the right things for the moment and working and partnering with public health on messaging.
Thank you so very much. This has been so informative, and especially to dispel some of our fears with monkeypox. The people in the community have been so fearful that we have another pandemic on our hands. So thank you very much for sharing information about this. I think today was an amazing session because we learned so much about the new variants. We learned so much about what the summer looks like, whether we should continue to mask, what about vaccines, and most of all about the oral antiviral medications. Thank you so much, Dr. Lynch, for giving us time. And thank you so much for shedding light on such important questions. Thank you very much. And thank you, Priscilla.
Thank you both for having me on again. And good luck, everyone. I hope you're doing well.
Thank you. So there are links in the chat where this will be uploaded. You can share with friends and family. Some other links in there again for the COVID assistance, and we will be back hopefully in the next couple of weeks with another update. Stay healthy, and we'll see you soon. Thank you.